Yeah. All right. Whatever works for you, buddy. I am proclamating that, I don't know. It doesn't matter. No, can you give me a white? Somebody give me a white balance over there on mine. I'll have Jimmy do it for free. You guys got mic check? Mic check good? Mic check, mic check. Test 1 2 1 2. Test 1 2 3 4 5 6 7 8 9 10. Test 1 2 1 2. Hello, hello, hello. Test, test, test. Hello, hello, hello. No malt box. Are we good on the white, Jimmy? All right. 1 2 3 4 5 6 7 8 9 10. Test 1 2 1 2. Are you guys hearing me in the mic and the speaker? You are? Okay. All right. Sounds good. Have a day.
I don't really think you're going to need it. That one is?
I know, I'm excited to watch you on that one. We're going to be up in the middle of the night tracking. So, watch your step, everyone. Yeah, thank you. Good morning, everyone, and a huge thank you to the folks here at M Health Fairview St. John's Hospital. James, to you and your team, thank you once again for welcoming us, but also our timing is really good for several reasons on this. The rankings of the states and the nation's best hospitals just came out in U.S. News and World Report that we watched, doing a very small percentage end up on that list. There were multiple M Health Fairview ones, including St. John's on that list of the top 12 hospitals in the state of Minnesota. So thank you. And as you saw, that is the staff that is here, from everyone from facilities maintenance to the nursing corps that's out here to the physicians. And as we said, people want their local hospital to be there when they need it. They want to receive quality care and they want to get back to their lives. And being able to do that, making sure that the healthcare system, and again, yesterday, Minnesota was named as a top 3 state for healthcare, and that's because of the people that are here, the systems across the state. Meaning whether you're in International Falls or in Rochester, Minnesota, you can expect to get quality care in a timely manner and a financing system that makes that work. That piece of it is always under stress, and it's one of the reasons we're here to celebrate today. Today coincides with President Johnson's signing of the bill that put Medicaid into law 60 years ago today. An incredibly visionary piece of making sure that quality health care was available to all Americans. Over those 60 years, countless Americans have counted on Medicaid, and you'll hear from the folks here who know that. That'll be mostly children, that'll be mostly our parents, and that'll be mostly people with disabilities. And it improved their quality of life and made it a priority for this country. We are now dealing with the potential that for the first time in those 60 years, a real threat to Medicaid's future is looming. With the piece of legislation that passed in Washington, the implications for Minnesota alone, and you'll hear from Commissioner Campbell talk about this, 140,000 people will lose their access to that care, and about $1.1 billion, because it is the patients who get it, but it's also the providers that count on Medicaid as a reimbursement tool to make sure we're able to fund great facilities just like this. So we know that there's work to be done, but I think today, in celebrating the achievements of St. John's, celebrating Minnesota's achievement as a top healthcare state, and knowing that we only did that in partnership and that Medicaid was a huge piece of that, we want to acknowledge that today. And so what I'll do at this time is I want to turn it over to Commissioner Campbell to talk a little bit about this. You're going to hear from CEO Herford, you're going to hear from some of the providers here, and I'd also like to note we've got Representative Zhang and Knorr here, that Minnesota legislators are the ones that have made it possible for Minnesota to be able to go above and beyond. And why Medicaid's a big piece of it, things like Minnesota Care and implementing those things have made a big difference. So I want to thank the legislators who've made that possible, and to all the physicians who are here and all of the staff and nursing staff. We're incredibly proud of what we do here, because what it means is Minnesotans' quality of life is better. It makes it a better place to live. So if I often say is, I want Minnesota to be the best place in the country to raise a family. Health is at the cornerstone of that, and each and every one of you make that so. So with that, Commissioner Campbell.
All right, well, good morning. I'm Erin Campbell. I'm the Commissioner at Minnesota Management and Budget. I'm going to get into some of the specifics here, but I want to point out that here in Minnesota, state law requires that we pass balanced, fiscally responsible budgets. The Federal Reconciliation Act is making that much more difficult, because it's passing costs traditionally covered at the federal level to state and local governments. Our current projections show that across the state, we will lose an estimated $259 million in federal funding in the current biennium, and nearly $1.1 billion in fiscal years 28-29. Keep in mind that the new law will be implemented over several years. Once it's fully implemented, the loss of federal funds will cost entities across the state of Minnesota a combined $2.5 billion per biennium, if not more. The impacts occur in 3 ways. First, in some cases, costs will automatically shift to the state because services that have historically been paid for in whole or in part by the federal government are required under state law. If the federal government doesn't fund them, the state has to do that. You'll see these costs, which are currently estimated at $155 million in the current biennium and $12 million in the next, picked up in the November forecast. An example would be $10.5 million in reduced emergency medical assistance funded through the traditional federal rate structure in fiscal year 27. Second, there's a significant cost to comply with the act that would be shouldered by state and local governments. We'd expect the legislature would need to act next year to pass legislation and appropriate funds. Those additional costs total about $15 million in the current biennium and $119 million in fiscal years 28 and 29. An example is an estimated $86 million beginning in fiscal years 28-29 for the newly required SNAP benefit state share. Third, there are places where other entities, like counties and individuals, are losing federal funding that the state is not required to cover, but where we would expect considerable pressure or loss of important services. We'd expect this will create pressure for the governor and the legislature to act and backfill resources, which may be challenging in our current budget environment. We estimate those impacts to be $34 million in the current biennium and $946 million in fiscal years 28 and 29. Minnesota Management and Budget is working in partnership with other agencies to get through the 900-page bill to analyze the potential impacts to Minnesota, and we still have a lot of work to do. There are some impacts we won't fully be able to measure until we have some clarification, implementation details, and data from the federal government. I would like to just spend a couple minutes highlighting some of the preliminary data that we've identified so far. As the governor mentioned, more than 140,000 Minnesotans are expected to lose coverage, and healthcare providers will experience a significant rise in uncompensated care. Minnesota will lose some $1.4 billion in federal funding in the first 4 years alone. Counties will face hundreds of millions of dollars in added administrative costs, and that's just in Medicaid and healthcare. When we look at private health insurance, we'd expect health insurance premiums will raise by for at least 89,000 Minnesotans, and more than 62,000 Minnesotans are expected to drop their coverage. New administrative barriers will make coverage harder to get and maintain. If we look at nutrition or the SNAP program, error penalties and reductions in federal reimbursements for administrative costs to administer the federal program will cost Minnesota about $125 million. Some 29,000 Minnesotans will be newly subject to work requirements that could create barriers to eligibility. And the SNAP nutrition education program will be eliminated, a $9.5 million a year loss that also affects 85 full-time equivalent jobs. And finally, in the area of clean energy and electricity, the loss of clean energy tax credits could result in higher electricity costs for consumers and state government and create barriers to progress combating climate change. Minnesotans would have to pay 10% more for electricity by 2029 and 25 to 40% more by 2035. The loss of tax credits and clean energy investments could result in 15,000 fewer jobs for Minnesotans and a $2.6 billion loss in gross domestic product by 2035. Here's the reality. It took only one session for majorities in Congress to push through the fundamentally ill-conceived piece of legislation, but Minnesotans, like other Americans across the country, will be paying for this decision for years. With that, I'd like to invite DHS Deputy Commissioner and State Medicaid Director John Connolly to the podium.
Good morning, everyone. Thank you, Governor Walz, for having me. Thank you, Commissioner Campbell. Thank you to mHealth Fairview for hosting us. I was asked to share perspective on the cuts coming our way by the federal reconciliation bill signed into law on July 4th. It's not very birthday-ish, I know, but it's important that everyone know what's coming as best we know at this moment. I want to emphasize that we're learning new things every day about the consequences of these changes, both from our own analysis and in the work of national organizations and our partners here in Minnesota. I'm giving you a snapshot of what we know presently, and possibly the biggest missing piece of information at this moment is administrative guidance from the Centers for Medicare and Medicaid Services, or CMS, which may be some time coming. We anticipate the number of people who will lose coverage, as the Commissioner said, over time in Minnesota to be upwards of 140,000 people. And again, that will get bigger over time. We expect Minnesota also to lose $1.1 billion in funding during the first 4 years of implementation, and those losses will also get bigger over time. Counties will also face millions in new administrative costs. So let's dive into some details. First, new requirements will reduce enrollment and service in 3 key ways. The legislation requires adults without children to resubmit their eligibility paperwork every 6 months, not just once a year. This increases churn in enrollment in the program, meaning people will lose coverage because they can't complete the paperwork even though they're eligible. And also, administrative costs for counties will increase because they need to certify eligibility. Adults without children and parents of children above the age of 13 will also be subject to a community engagement requirement or work requirement of 80 hours per month. Again, this is a paperwork challenge for both enrollees and counties, and I'll note that we here at DHS call this a work reporting requirement because the large majority of working age people in Medicaid already work or will be exempt under the new federal law. The new requirement here is really the reporting part. Adults without children will additionally be subject to new fees of up to $35 per service. In the long term, people who can afford early care end up needing more expensive care, and providers will see more uncompensated care. That's bad for people, it's bad for healthcare providers, and it's bad for budgets. The legislation eliminates eligibility for many categories of lawful immigrants, reducing their access to affordable health care. Now let's talk about the broader impact on our healthcare system. The first big impact is already in effect. It's a prohibition on federal funding to certain reproductive health service providers for 1 year, which will result in up to $154 million in losses for providers in our state. Another already in effect, the legislation caps or reduces state-directed payments in expansion states, which Minnesota is. This provision lowers the federal limit on state-directed payments to these providers from the average commercial payment rate to Medicare rates. It also limits retroactive coverage from 3 months to 1 month for adults without children, or 2 months for all other eligibility groups. The financial impact for our providers is $31 million in reduced federal funding per year and $9 million in reductions in state funding. I'll go a bit deeper into why this is such a challenge. Retroactive coverage is for people who come in for care without health insurance but are and have been eligible for Medicaid. Currently, we've been able to enroll them after we ensure they meet requirements for the program, which takes a little time, but once they're enrolled, Medicaid can cover care that they received in the previous 90 days. By shortening that period, providers will end up with more uncompensated care again, and people will have more out-of-pocket costs or medical debt. Finally, let's look at impacts on the state's financial stability. The bill imposes stricter rules around state penalties and sanctions by CMS related to eligibility errors exceeding 3%. The bill removes CMS's ability to waive any penalties when states implement corrective action plans. Penalties could be as much as $20 million for each 0.1% above the 3% limit. H.R. 1 also reduces federal matching funds to states for emergency Medicaid, or emergency medical assistance as we call it here in Minnesota, which supports people during medical emergencies. The reduction is from 90% to just over 50% in support for those services, a $13.6 million reduction in federal funding per year for Minnesota. The bill also prohibits new or increased provider taxes and gradually reduces existing taxes to 3.5% from 6%. Federal revenue loss again for hospitals could hit as much as $1 billion annually in future years. We're still working on refining that analysis, but the initial projection is extreme. So again, that was a brief overview of the impacts of an expansive bill that we're still analyzing every day. We wanted to share with you what we know at this time, but the overarching theme is that Medicaid funding reductions and eligibility requirements that are new through this bill will be dramatic and represent significant changes for Minnesota. It will impact healthcare providers as well as the people who count on them to stay healthy and to care for them when they can't. In particular, the expansion group, adults with low incomes who do not have children, will face new challenges on top of those they already experience. It will also pose challenges for the state budget. These impacts are interactive and cumulative, not just for the state and counties, but also for individuals in the program or who need access to the program. meaning that people who no longer qualify for health coverage through Medicaid could be losing other supports like nutrition support through SNAP, spiraling them even further into poverty. I appreciate the time to share these impacts with you, and yes, to celebrate the birthday of this foundational healthcare program, Medicaid, that has helped so many in Minnesota and across the nation in their times of need. So thank you, and glad to turn it over to the CEO of M Health Fairview.
Well, thank you, Governor. Thank you, Commissioners. It's really nice to be able to host you at St. John's. I want to say a little bit about St. John's Hospital. So this has been, its roots are a community hospital. It's really wedded to the community that it serves. It's also one of the best tertiary hospitals in the Twin Cities, recently named #1 in cardiac care. So that balance of being able to provide for the community and to be able to provide that higher end care is critical. And it's being named in the U.S. News and World Report is terrific validation of the work that so many of the people I see in front of me do every day, our physicians, our nurses, our techs, etc. I do want to say a little bit about the Medicaid cuts, and my team will probably not be all that happy that I say this, but healthcare financing is a Jenga tower. And what we're doing is we're taking pieces out. And at some point, this is all going to collapse. And all of those pieces relate to each other. So none of this affects the access to care. We'll be here. But the problem is, without Medicaid coverage, people will show up in our EDs more acute, sicker, later, and with bigger issues for us to deal with. And we will be here. But let's be, clear about Medicaid financing for us in terms of what it reimburses is about 63 cents on the cost dollar. So for every Medicaid enrollee, we lose money. Now, obviously, if they're not covered, we'll lose more money. We make that up in terms of commercial reinsurance, right? So businesses pay insurance. They pay more. So this, in my mind, represents a hidden tax. It's a hidden tax not only on individuals, it's a hidden tax on business. And we depend on our business climate. We're very lucky in Minnesota to have the thriving business climate that we do. This is going to put more stress on that because their premiums have to go up, because at the end of the day, we've got to keep these facilities open. We've got to be here for our community. We've got to be here for those who are sick, who need us. And I'm very proud of the work that we do in terms of working beyond the walls of our hospital. We recently won the Fred G. McGaw Award from the AHA about our work in community. We were selected the best in the country. That also is going to be impacted by this, because we do that in part by being able to leverage the work that we have and the people that we have to be able to step out of those walls and engage with our community. We have cultural brokers, we have vaccine programs, we have various things that we do to try to keep people out of our institutions, out of our hospitals. And then if they need care, to try to make sure they get to adequate primary care, adequate specialty care. Without coverage, that's in peril. And that changes the whole dynamic of how healthcare has been built to work, is being able to have access to ambulatory care, and when needed, that ED is open 7/24 by 365, staffed by amazing people to handle those emergent conditions. What we really don't need are people who are using the ED as their primary care center. It is the wrong place. It is expensive a place to be able to deliver that care, and ultimately it's too far upstream. We need to be able to work much more quickly to be able to handle acute care, chronic care, etc. So with that, Governor, I truly appreciate you, your administration, the work of the state. It's a privilege to be in Minnesota. As you know, I'm a transplant and have really enjoyed my time here. I'm very proud of our organization, very proud of what we do every day, and we will continue to do it. But we have to be factual. We have to be looking at the rationality of, we will have to make changes based on the kinds of numbers that the Commissioner talked about in terms of how do we provide that care and maintain our ability to have access for the people that we serve and the communities that we serve. So with that, thank you, and it's my privilege to turn over the podium to one of our amazing doctors. Dr. Navki, would you like to come up?
Thank you. Thank you. Thank you, James. Thank you, Governor, for being here. Good morning, everyone. Thank you all for being here. My name is... Closer? Sorry, I don't want to throw my voice out. I apologize. My name is Sakina Naqvi, and I'm a pulmonary critical care physician here in the Health Fairview system. I've been a resident in Minnesota for about 20 years, and I've worked in the Maplewood system for about 11 years here at St. John's. I'm honored to join all of you here today on the 60th anniversary of Medicaid, and we appreciate all of your presence as we set out to serve a very diverse community here. As medical professionals, and has been so eloquently stated by speakers before me, we do not dictate who walks in through our doors. And at the bedside, as a provider, I myself and my colleagues do not concern ourselves with whether or not a patient has the financial ability to pay for the care that they require. Our oath as medical professionals is sort of steeped in providing the best possible outcome to anyone who is in need, avoiding harm and injustice to them. And we arrive at the hospital armed with these principles and hope to deliver the best possible outcomes for our patients. The last several years have seen significant challenges for dispensation of care. I myself was an ICU physician during COVID, and it was very challenging times, and the landscape is very different now than it used to be 5 or 6 years ago. Minnesota is not different from any of the other cities or states in this. Anyone who has themselves required medical attention, or certainly knows people who have, know that going to an emergency room is, maybe a multi-day challenge. People go armed with overnight bags because they might just be sitting in a waiting room to receive care. Most of my patients would rather wait overnight at home and get sicker, or else, if it's a Friday night, call the clinic on Monday morning to say, hey, I need this, and may actually get quicker care than if they went to the hospital. Hospital employees as well, this is not just physicians, medical assistants, everyone over here is sort of dealing with this ever-changing landscape and making accommodations every day to ensure that, we keep patient safety ahead of everything else, and we have good outcomes no matter what. Whether that means administering care to a patient in a waiting room, or if the patient is lucky enough, they may have the privacy of their own room, where we can have private conversations with them as opposed to being separated by curtains in an emergency room. I think everyone is aware of this. When patients get admitted to the hospital, the first order of day is to sit down with the team and decide how soon we can get them out of the hospital. And that is not what should direct medical care. And really what holds us up is how we can get them out to a safe place. A lot of times people are coming in just because they don't have a safe place to live. And that is not the role of a hospital. And the system is broken, and it continues to fray. The pressure that patients, that hospitals, various medical professionals are facing, doesn't feel patient-centered at all. And, with some of the proposed cuts to Medicaid, patients will and do continue to avoid being evaluated in the outpatient setting. And when they're lucky enough to get into our clinic, sometimes after, several months long of wait, they realize that the medications that we are prescribing are well out of their reach, and they might as well have gone to the emergency room to at least be treated that one time for immediate management of their chronic illnesses. Within the last week, I've had 2 patients who came to my clinic who stated that they had lost their health insurance, and each visit to see me cost them $500. And this was before any medication or test was prescribed. It has made me, and I'm sure a lot of my colleagues, alter the way that we approach evidence-based medicine. If the cost of one inhaler that I prescribe is $500 and I'm prescribing 3 or 4 others, what about all the other medications that are being prescribed? And how do patients and their medical teams pick and choose what the best care to deliver is for the best patient outcome? As this is happening, all the while in the background, the patient's medical illnesses are sort of chipping away and getting worse, and they reach a tipping point where they end up back where they don't belong, in the emergency room. And, as other speakers before me have said, the emergency room is not a clinic, and unfortunately, this sort of perpetuates a cycle of bad care. And, the healthcare systems across the country have stepped up creatively and urgently to hold a safety net together for patients. But we understand that hospitals alone cannot solve these structural issues, and we need Medicaid to be strong, stable, and responsive to the real needs of our patients and our communities. St. John's is a place of healing, of hope, and unwavering commitment to the communities that we serve. And while we are proud of what we have built and our continued innovation to serve the community, we need continued investment in Medicaid. We need policies that recognize realities and face and support the care every Minnesotan deserves. Thank you so much for your time today. I will hand this back to the governor.
Thank you, Dr. Naqvi. Grateful. Well, thank you to Dr. Naqvi, and as you heard from folks, I just want to note to the press that's here there's just an amazing thing amongst all this massive change, the biggest one in 60 years. There's one thing that's been missing. There's been no press conference for the people who support this to stand up and tell you why it's so good. What are the positives of this? Because if the argument is this was about saving money and reducing the national debt, it did not do that. It shifted the money. It took Minnesota's federal dollars, which we are one of a handful of states that are payer states that send more in than we get back, and they shifted it to tax cuts with 85% going to the top 4%. So it means that all of this disruption, all of this change added $3.4 trillion to the national debt, undermined our healthcare system, all the while shifting that. I would think if you vote for a bill like this, you would have been holding press conferences across the state, standing in front of you and saying, the governor's wrong, the CEO is wrong, the doctor is wrong, the numbers are wrong, here's what it is. No one has done that because they cannot. So I can't stress enough. Medicaid and all these programs, we can always do better. This is not Medicaid reform. This is exactly as you heard it. This is a shift that is going to undermine. And when you heard those people that will not get coverage, keep in mind, federal law requires these folks, in addition to their morals code, to care for anybody that shows up here. It's far better to reduce your cholesterol than come in here for a bypass. That is a lot more expensive. That was the purpose. That was the purpose of the reforms around the Affordable Care Act and Medicaid being a provider of it. So when we finish with some questions here, I'm going to present the proclamation on Medicaid, but I think Minnesotans just need to understand, trying to put this out there, that there's a bunch of healthy people ready to go that are simply not working and collecting on Medicaid is wrong for so many reasons, but even if that were true, this is not the fix to that. That doesn't get at the heart of that. And so I think highlighting and educating folks and understanding that Medicaid, and I love James's analogy on this, it's the Jenga tower piece of this. And at some point in time, we're going to pull the wrong piece, and the whole thing's going to come down because that stress is there. With that, we'd be glad to take a few questions. Tom?
Speaking of the people who support this bill, Republicans like Congressman Tom Emmer say no one will be kicked off Medicaid unless you're an undocumented immigrant or you don't meet eligibility requirements or the work rules. And the taxpayers support that. First, how do you respond to that?
Yeah.
And then we'll hear from Mr.
Well, yeah, first of all, that is untrue. Secondly, I can't stress this enough again. Okay, I get it. You don't want to place somebody who's undocumented, they're in the system. This is somebody who's working, milking your cows, taking care of your kids. So your moral code says to hell with them, they get nothing. Well, we could have that debate. They're still coming here and getting care uncompensated, and we're paying for it anyway. It's more expensive. That is the stupidest reason to do this that you could possibly put forward. It is cruel, and it's based on trying to play on people's emotions that, you know why the healthcare system is stressed? Some undocumented person is getting health care. Not only that, they're getting preventative care, which actually saves more. That is, and I would wish all of you challenge them on that. I'll let the folks tell you on this who gets kicked off this and who ends up getting hit by it. And I will note this, last one. Disabled veterans, up to 99%, are also considered under this, so they can get their lazy butts out there and work too, according to Tom Emmer. That is nonsense. That's not how this works.
So I think 2 points are really important with respect to who loses eligibility under H.R. 1. I think first of all, just to clarify and to start with, Medicaid only pays for services for people who are undocumented in situations of emergency, so serious threats to their health or to their life. That is the only situation in which Medicaid can leverage federal funds to pay for people who are undocumented in their care. The second thing is, it is absolutely the case that anytime you add a new requirement for eligibility and enrollment for the Medicaid program, you will see reductions in enrollment as a result. So with the new work or community engagement requirement, with the twice annual renewals that we'll see for adults without kids, we will see reductions in enrollment among those groups as a result of the new requirements.
Will taxpayers save any money by doing this?
That is unlikely as a result of the new costs that we'll see as a result of avoided and then later uncompensated care, and we'll see folks show up in the emergency room for more expensive and exacerbated conditions.
Administrative costs or paperwork that's going to be done. You said on Monday $160 million, but that was an old estimate based on some requirements. If I interpreted what you said correctly, do you have any idea of what that might cost with today's numbers, with
So we're using $160 million as a minimum figure because that was a local impact note to estimate cost on a bill moving through the Minnesota legislature several years ago. So just as a result of inflation, we expect that figure to be higher now, just the cost of the workforce in counties. So that is a starting point in terms of the analysis, but we're continuing to refine that.
How do you get, $160 million figure? How does that add up? I know it's counties all across the state. Where does that money go?
So it has a few different components, but principally it's because workers will have to process more paperwork. And when we're talking about verifying that somebody is volunteering 80 hours a month or doing other things 80 hours a month, that's a very laborious and paper-based process in many cases. And county workers will have to make time, and counties will have to hire more people to process that paperwork. In addition, of course, to the twice annual renewals that are coming as well for a share of the program. So not only do they have the work requirement to process, but people will have their renewals twice as frequently, at least for certain beneficiaries. Yeah, so we've looked at a few different analyses from KFF, from the CBO, the Congressional Budget Office, and looked at some Minnesota-specific figures that we could plug into some of their formulas. So we're looking at what different organizations nationally and here in Minnesota are doing, and came up with our own Minnesota-specific estimate, but it's based on some of the different approaches that different organizations have taken. And so we expect $140 million to be the loss over time, because there are cohorts that are renewed every single month in the program. So we expect the number to start small or modest, and then gradually increase to 140,000 over time as people get renewed. No, this is principally as a result of people who lose coverage or can't gain access to coverage because of those new requirements. That's right.
Is that number including people who just would otherwise meet the requirements but just didn't complete the paperwork?
That's correct. So we see folks churn out of the program because they have new hours at work or an increase in income, and therefore are no longer eligible. So that's a natural part of how folks come in and out of the program. This is really an estimate of coverage loss as a result of the new paperwork and red tape as a result of both the work requirement and the twice annual renewals.
And what's the timeline on when they'll start losing coverage?
So both of those provisions take effect at the end of next year, 2026, so really beginning at the beginning of 27. And then, like I said, because there are monthly renewals, we'll start to see that number appear in early 2027 and then increase as the year goes on.
Assuming there's a special session that the government said what legislative fixes they need proposing?
Legislator needs.
This is one that's very, very difficult. And I would make note, too, of the ripple effect this will have throughout the market. When you talked about those people who won't any longer sign up, we're going to also lose the tax credits on the exchange that makes it affordable. And what will happen again is, this is a Republican philosophy, is well, people should be able to decide they don't want insurance. You know who decides they don't want insurance? Young, healthy people who don't want insurance. But you know who really needs it is when those young, healthy people become older adults. The risk pool needs to expand. So this becomes a very almost intractable problem. If this piece of the Jenga is pulled out, makes it very, very difficult. And so I think with the legislators, we will certainly be talking about it, but the scope of this, I mean, I'm at the point right now, they can't balance budgets. They run up the national debt. Leave us our federal monies. Maybe we shouldn't just pay our federal taxes. We'll keep them here. I guarantee you, with a state that's in the top 3 of doing this, we can do it. Arkansas sure the hell can't. Texas sure the hell can't. Florida sure the hell can't. But we can do this. So this idea that there's a savings in this is playing on a very dangerous emotion that this entire problem is caused by undocumented or people in the system yet getting health care. That is the biggest lie that has ever been perpetuated. This is far bigger than that. Every expert up here will tell you this. You go find me a healthcare CEO to stand with them when they give that line and see where they're at. I guarantee you that they're not going to be able to do it because they know what the finances are. So we'll work with our legislators, but I'm telling you, it's going to be very, very difficult. Okay, get one more. Yeah, I'm sure we're on the top of that list for waivers. Look, and once again, if you really cared about this, implement it. So weird that you would wait after November 2026 to implement this because you know everybody's going to hate it. And then it's already too late on that. So certainly we will try. We will try and get out there. And you didn't hear, I know some of you are experts in this and the folks who are up here. This whole thing with the error rates is simply stunning to me what they did on that. And actually being penalized for being better at this and sweetheart deals to get votes like the state of Alaska that has that, it's simply unacceptable. So Claire is trying to move us to a more positive place here. It's pretty hard not to get irritated about this one because once again, the pain this is going to cause, and again, I think there is a strong philosophical and economic argument to be made that our healthcare system still needs massive reforms and that there's a potential to try and find savings. This is about the opposite of that. This will actually exacerbate all those things. This is a cruel, unneeded piece of legislation that appeals to base emotions while parting the burden on all the folks that stand up here that provide that care. This is not all that different. That's what President Johnson knew at the time. That's why I'm going to present this. James, I'll present it to you and your team here that President Johnson signed a bill creating Medicaid on July 30th, 1965. Medicaid is foundational to Minnesota healthcare, supporting public health infrastructure across the state, including hospitals, community clinics, dentists, home care, nursing homes, and so much more. Medicaid is a lifeline, especially providers in greater Minnesota. The significantly reduced number of uninsured Minnesotans and the cost of uncompensated care that threatens a clinic or a hospital's sustainability. Medicare covers more than half of substance use disorder treatments in Minnesota and is the largest single payer of mental health services in the state, supporting people through mental and physical challenges. Medicaid's ability to reliably and successfully serve the people of Minnesota has been undercut. Healthcare in Minnesota is some of the best in the country, thanks in part to Medicaid. Medicaid allows Minnesota to invest in the health of our communities, which is an investment in our future. For 60 years, Medicaid has provided critical access, support, and services to people across our state. Medicaid is vital to Minnesota's health and is a cornerstone of our quality of life. Now, therefore, I, Tim Walz, Governor of Minnesota, do hereby proclaim Wednesday, July 30th, 2025, Medicaid and Medicare Day. James, to you. Thank you. Thanks. You got any? All right. You got two not off topic. Yeah, you came out here. Yeah, we'll do an off topic so they're not in front of the M Health Fairview, unless you wanted. So. Can I do that over here? We do have a Council General of
Oh, this one?
One quick photo. Doctor, you want to stay? James, you want to get in here? Sure. Legislators?
Do you want all of us, Governor?
Watch your step, everybody.
Do you want
I think one of our
Here we go.
You can't. It's going to be bad.
Thank you. All right, then just one more right here. 3, 2, 1. Perfect. Thank you.
I'll tell you what, I did notice that the legislators didn't shave.
Hang on a second, you guys. We got to get some cameras in here.
Stay in touch. Hey, thanks so much. We know the system then together.
Yeah.
You mentioned 2 days ago stopping. Yes.
Yeah, I don't know. And I just have to tell you that we are getting deeper into that. There's about 1,600 providers in that. Every one of those will be scrutinized. And I'm talking even real time right now, but at some point those will all be released because I believe the public anyway, once they get out there, you'll be able to separate who's in there. But our intention is that this program, as you heard, well-intentioned, good, but simply has too many loopholes.
What's the meeting take until news reports came out for those payment stamps out?
They were stopped before those came out, which several of them were. The issue was using the new powers that we were granted by the legislature and putting them in. And I think some of it was me directing very very clearly to them that what I understand is, and this is not about cruelty or whatever, there will be people who are playing by the rules and that this is doing what it's supposed to do, which is incredibly important, that will be caught up in this and slowed down. And I think it's just making the case, and I made it very strongly to them, is we have to err on the other side of this or the program won't work at all.
Governor, are you glad to see that the State Patrol is going to get a third-party review of Capitol security? Is that measure overdue?
I always think it is, and I think these are things that have never happened before. We've never seen a political assassination on the level that we saw here. I think so, and I think the one thing about that, I think all of us are finding out, Capitol security is a complex web between the county, between the city, between the State Patrol, and also that we have an advisory board that doesn't really have a whole lot of power on Capitol grounds, that bringing those folks in, always getting another eye on it, I think is good. I think just some, we have to have the discussion. Are we going to use metal detectors? Are we going to talk about guns? I think some of them, though, it's convenience and it's a Minnesota thing, but I think we're all grappling with this. Why are so many doors open all the time? And I think, unfortunately, in our world, that makes sense. So I think bringing in experts on this to put an eye on it and tell us, because sometimes when you're too close to it, and I think we're going to have to be told by outside folks, look, we really respect your open culture, but we really believe that the risk is too high in doing that. And so I'm glad they're doing it.
What are you meeting with leaders on today?
This issue. We're going to talk this afternoon. I think they're going to bring up their concerns. It's the 4 caucus leaders, myself. DPS will be briefing them on where they're at right now, State Patrol, and then seeing where they're from. Because, again, we have to honor the separation of the branches. The issue I talked about is stepping in that House chamber. I have to be invited to go in there, as we speak to them. And the same thing is true of the security. What role does the Sergeant at Arms play? And then I think in a citizen legislature, how are we getting those local police departments? And they're as far flung as Grand Portage down to Worthington. And how are all of them acting together to get those local folks at their home? I think the Capitol, I feel very confident we can handle that, and there's security measures we can put in. I'm still deeply concerned about the legislators and their families when they're off campus.
Governor, any update on the cyber attack in St. Paul? Have you heard from, been in touch with them?
No, nothing at this time. We've got 13 National Guard who are cyber experts, and I think you've heard this. Many of these folks work in the private sector on their full-time job as cybersecurity experts. Minnesota is actually probably the top state for this. We've advocated to be a leadership in that. Those folks are activated now. I think the city did really prudent. Once they spotted this, they basically closed all the doors and shut things down, and now it's about walking back through that as we put the labels in place. And I've not received an update as of this morning. Last night, as we heard, that there was no more breaches, and the way I understand it from the city, and I'll let them speak for themselves, their concern was with the employee data, not necessarily citizens' data that was in there, because that's the next piece of this. But I think it highlights this issue, attacking a water treatment plant. Our fear has always been attacking a cooling system in a nuclear plant, attacking a highway system, controlling how those all work. These are very dangerous acts. They're acts of terrorism and extortion, and now trying to use the expertise that we have both in the state but also federally to help us figure that out. But as of this time, I think the city of St. Paul did everything they could immediately. It was over the whole weekend working together, and then letting folks know that we have these resources. I think I saw some people misinterpret. We had the National Guard out there in an armed capacity. That's not it. These are cyber experts. These are security experts that work for the National Guard. And these state actors, and some of you heard me say this, it's hundreds of times a day that we get these attacks that try and come in. You get them. Just fill this out. I think the one that was around here, I apparently have a parking ticket with DPS or something. I think all of you got that one. Those are very simple but very effective, and this was the same type of thing, I think. And we didn't, I'll let them speak to it, the denial of service types of attacks, but they can be really debilitating. But thank you all for coming.
Thank you, Governor. All right, we'll go this way. Got it. Thanks. Thank you. Thank you, everybody.